Hi, my name is Delphine Chen. I'm a nuclear medicine physician at Fred Hutch Cancer Center and University of Washington. And today I've been asked to talk about navigating scans. So I'd like to thank the organizers of the meeting for inviting me to present on this talk and talk about how we think about using imaging for patients with neuroendocrine tumors. So these are my disclosures. So let's start with the commonly used imaging modalities that we often order for patients with neuroendocrine tumor. I've ordered the modalities that we use based on the reason for the exam. So at the time of diagnosis, we consider things like endoscopic ultrasound to find the primary tumor, computed tomography and MRI, which people are very familiar with. Those provide us with anatomic imaging information, and potentially PET, CT, or PET MR, usually Dotatate, and that's usually used to guide biopsy. Very infrequently, we might use FDG PET if there's a diagnostic dilemma. We also use CT, MRI, and Dotatate PET for initial staging. Again, FDG very infrequently used, most commonly using Dotatate PET. And then for restaging or monitoring or surveillance, again, using CT, MRI, and PET. And then we use Dotatate PET for looking at treatment eligibility with PRRT or lutetium dotatate. In this talk, I'm going to focus primarily on CT, MR, and Dotatate PET. So first, let's talk about computed tomography, or CT. Everyone is pretty familiar with this modality as it is widely available, and it is often the modality that detects the presence of a neuroendocrine tumor. We commonly use it for treatment monitoring because we can get a good sense of the anatomic changes of the lesions. Because the liver is often a site of metastatic involvement with neuroendocrine tumor, we often get multiphase contrast CT. Once we know that we are trying to find neuroendocrine tumor sites, we will use multiphase contrast CT to better see those liver metastases. Additionally, as you can see, we can identify bone lesions as well, and then we use anatomic information such as the lymph node. If you see the arrow in the middle of the top axial slice right next to the spine. So it gives us really good anatomic information in addition to, as you can see, the liver metastases, the arrow on the left top image. And then in the bottom middle of the abdomen, there's a mesenteric node. And then on the right spine image, and with arrows showing sclerotic lesions, that shows where the presence of bone metastases are. The next modality we'll talk about is MRI. So with MRI, we again use multiphase contrast exams to look at both pancreas and liver lesions. Again, the reason for that multiphase contrast is that the neuroendocrine tumor sites are very vascular and they enhance really quickly, usually in what we call the arterial phase, which means shortly after we inject the contrast, the arteries deliver the blood flow to the neuroendocrine tumor metastases and they enhance really brightly on those early phase images or arterial phase images. So if you look at the top row on the right, that really bright spot in the middle is the contrast agent in the aorta, meaning it's in the arterial system. And then in the liver, you can see bright spots, and those are areas of enhancement that are showing that early contrast enhancement in the metastases in the liver. Delayed imaging with hepatobiliary contrast agents like Eovist actually help delineate the anatomic size and extent of the tumors really well also. So if you look in the second row on the right-hand image, that is a delayed phase image using Eovist, and it shows those dark spots. Those are the metastases. And as you can see, it shows them really well. In that second row to the left, that's an earlier phase of contrast, meaning when we do an MRI, we're getting multiple pictures as the contrast is injected. So as the contrast moves from the arteries into the organs and then into the veins, we get a number of different pictures along the journey, if you will, of the contrast agent flowing through the body. So that's why when you look at the top row, that arterial phase image that I showed you, it's again somewhat arterial phase, but it's a later arterial phase image. So now you can see that more of the agent is going through the liver and you don't see the metastases as well. And then on the right side, you can see the metastases really well because now the agent is taken up really well by the liver, not so much by the metastases. And so we get a really good look at the anatomic information. Finally, we get more biological information from diffusion weighted imaging. So if on the bottom row on the right, you can see that there are multiple bright spots that correlate with the dark spots seen in the second row image. And so those are areas showing diffusion restriction, and that further confirms that these locations are metastases. And so MRI really gives us a nice view of the anatomic extent of liver metastases, and that you can see similar findings with pancreas lesions. Now, for dotatate, we have two agents available, gallium-68 and copper-64 dotatate. These are generally considered the most sensitive for detecting well-differentiated neuroendocrine tumors. They may not detect very small liver lesions, which is why it's important to get a multiphase CT or MRI to put together with the Dotatate PET. That will improve the sensitivity. And for small lesions in the bowel, when you're trying to find the actual primary lesions, sometimes intraoperative ultrasound can also be more sensitive. But Dotatate PET can often be used to find those small bowel lesions as well. And so putting those imaging modalities together increases the likelihood that we can find those disease sites, particularly the primaries. Also, we use Dotatate PET for determining lutetium dotatate or PRRT eligibility. And so we won't go into that in as much detail. We'll focus more on the diagnostic utilization. In terms of gallium-68 versus copper-64 dotatate, there are no published direct comparisons of the two different tracers. There is a single study that compares gallium-68 dotatalk with copper-64 dotatate, and on the right, you'll see a screen capture of a figure that was in that publication showing that there is a small bone metastasis that you can see on the copper-64 dotatate scan, which is in the middle row. But in the top row, which is the gallium-68 dotatalk scan, you don't see that lesion very well. On follow-up, so you can see the dates of the scans there, about a year and a half later, they obtained a gallium-68 dotatalk scan, and now they can see that image. So this preliminary study suggested that copper-64 dotatate was more sensitive than at least gallium-68 dotatalk. However, dotatate is the same ligand. So when you're comparing gallium-68 dotatate versus copper-64 dotatate, we are using the same peptide to target. So it's a little less clear whether there's really a difference between gallium-68 dotatate and copper-64 dotatate. So in practice, we treat them equivalently. Some of the advantages where you might want to use copper-64 dotatate over gallium-68 dotatate for specific reasons. Copper-64 has a longer half-life, so potentially we may be able to use that for dosimetry. It's also not indicated for pediatric patients because the radiation dose potentially is a little higher, although we do give a low dose for imaging. So for adults, the radiation exposure is fairly equivalent. Gallium-68 dotatate is indicated for pediatric patients, and so that's usually the preferred tracer for our pediatric patients. In terms of detecting the tumor site, so I'm going to show a few cases. This is one case where we used the Dotatate PET, showed very nicely that there was a rectal primary. So first on the left, you see what's called a maximum intensity projection image. So it's a whole body image. On an image display workstation, you could rotate that to get a 360 view of the images. And what you see in this particular case is that there are multiple liver metastases. And then in the pelvis, you can see several black spots. And I have focused more on those black spots in the axial images to the right of the screen. So in the top row, you can see arrows pointing to a bright spot that looks like it's in the colon. So in the very right images, you can see the CT and you can see the bowel, which is what we call serpiginous, but very curvy looking structures there. That is the bowel. And you can see that focal hotspot in there that the arrows are pointing to, and that was considered the primary site, and that is most likely the primary site given the images that we see here. Additionally, there was another black spot, that larger black spot, and on the bottom row, you can see that there are arrows pointing to that as well. And when you look on the CT images on the very right, you see a soft tissue mass with some white spots in it. That's a calcified mesenteric node, and so that further confirms that that was probably a rectal primary with a mesenteric nodal metastasis nearby. In terms of visualizing bone metastases, Dotatate PET can also be very sensitive and helpful for identifying those sites. So this is a comparison with this patient actually ended up getting an FDG PET and a Dotatate PET in the workup while they were trying to determine whether they had a neuroendocrine tumor or not. And on the top, you can see the Dotatate PET shows a really bright spot, and that bone is called the left ischium. And you can see that focal spot that on the CT, it's very hard to see whether there's actually a lesion or not. So if you're looking at just the CT, it would be very hard to say that there was a metastases based on the CT appearance. When you look at the FDG PET, it didn't have any FDG uptake. So these imaging features together suggest that this is a site of well-differentiated neuroendocrine tumor. And so in terms of following these bone metastases, we still don't often get the Dotatate PET, just to follow bone metastases, especially if they're small volume. They're likely not going to cause any problems. And what we're more concerned about is liver and nodal metastases. That said, though, in some patients, when they have extensive bone metastases and they're hard to see on the Dotatate PET, we may consider using the Dotatate PET for surveillance in that situation. This is another example just showing the benefit of putting together the Dotatate PET and contrast CT and comparing the contrast CT findings with non-contrast CT. So you can see on the top two rows show it's a contrast enhanced CT in the arterial phase. So we have obtained an image on the CT very shortly after injecting the contrast. And I have two arrows pointing to two liver lesions that we're just going to focus on. So they're very bright on that arterial phase image on the CT. So you can see that there's a lot of enhancement. On the Dotatate PET, you can see there's really high uptake. And so again, confirm that there's Dotatate uptake, and that does confirm that well-differentiated phenotype for the neuroendocrine tumor. On the bottom row, you can see the delayed phase image. So this is what we call the portal venous phase image on CT. You can still see those lesions, but you can see that they blend a little more into the background. And then on the right side on the bottom row, you see the non-contrast CT. In this case, you can actually still see those lesions, but oftentimes on non-contrast CT, it can be very hard to see those lesions. So in this case, you see what we call hypodense lesions on the non-contrast CT images, and that's what those two red arrows are pointing to. But if you look at the rest of the liver that you can see on the top row, there are multiple other sites where there's uptake on the Dotatate, and then there's arterial enhancement. But on the bottom rows, especially in that non-contrast CT, you don't see those as well. And even on the portal venous phase, some of those aren't as easily seen as well. So that is why we like putting together the multiphase CT and Dotatate PET images. And then to compare the contrast CT with MRI, you can see that on the different contrast CTs, on the two left columns, it's somewhat hard to see that lesion that we have the arrows pointing to. But on the MRI, which is on the very right side, you can see those neuroendocrine tumor sites very clearly. And so when there are a lot of liver metastases, there are advantages to potentially using MRI. If we can't see them well on CT, we can use MRI to follow the anatomic extent. Finally, this leads me into some of the reasons why we might choose a PET MR over a PET CT. So this is a PET MR case. You can see that, again, I have yellow arrows on the bottom two rows that point to the liver metastases. And even without contrast, you can see these liver metastases really well on the non-contrast MRI. And paired with the Dotatate PET, we can then potentially use those to follow those as well. So non-contrast MRI is not a standard technique for doing anatomic measurements. When precise anatomic measurements are needed, you still need a contrast MRI, especially if you're using this for PRRT eligibility. This can be a nice way to see the liver metastases well on the MRI and still correlate those with the contrast CT or contrast MRI. In terms of how we think about frequency and scan selection for surveillance, because I get that question a lot, like how often should I get scans and which scan should I get to see if my tumor is progressing? So first we look at the biology. So is it a low grade, intermediate grade, or high grade? And this is just a visual illustration of how we think about how often you need to get the scan. So if you have a low grade lesion, generally we don't get them as frequently as, for example, if we have a high grade lesion. Also, if you're on treatment and you're getting active treatment and wanting to assess response, that might be another reason why you would get more frequent scans. And CT and MRI are really the core of surveillance imaging for looking at changes in known metastases and assessing treatment response. Dotatate PET is used less frequently. While we can use it potentially for functional response, that data is not solid, and so we don't commonly use that. We most often use it at the time that there's progression and we're thinking about PRRT, and that's when we would use Dotatate PET once we've established the diagnosis of neuroendocrine tumor. In terms of recommendations and data, so there was a large retrospective series published by the Australian group looking at surgical resection, but there are also multiple other cooperative groups and groups that you know well, like ENETs and NANETs, that have brought experts together to try to identify what those imaging recommendations are. So I'm not going to read this all for you. You can take a look at this. The slides will be available to you, but these are some of the recommendations that have come out for what kind of imaging should be done after surgical resection. And when you have low grade with certain types like appendiceal or rectal neuroendocrine tumors, if they're completely resected, sometimes follow-up imaging is not recommended based on the recurrence rates that we see. And so just to highlight, this is just a summary of what the methods were in that particular study that published all the different recommendations from the different societies and expert groups. But the single most important factor that drove the follow-up decision imaging selection was histologic grade. So this really plays into how we decide which imaging should we do and how frequently. And finally, a word of caution when looking at and interpreting Dotatate PET scans on patients who have been started on a somatostatin analog. Sometimes we can see what is called pseudo-progression after starting a somatostatin analog. What I mean by that is, generally when you get your first Dotatate PET at the time that they're either diagnosing your neuroendocrine tumor or they're performing initial staging, usually those patients have not been started on a somatostatin analog. Once they've determined what type of neuroendocrine tumor there is, they'll follow them by CT, but in the interim, they may have started a somatostatin analog for disease control. Then the Dotatate PET is obtained to confirm. The typical scenario is there's some concern about progression on the CT or MRI, so they obtain a Dotatate PET to get a better picture of the full extent of disease and confirm whether there's progression or not. But then now this Dotatate PET has been obtained after the patient has been started on a somatostatin analog. What a somatostatin analog does is that it decreases the background activity within the spleen and liver. So if you see the thick red arrow on both scans that's pointing to the spleen, you can see on the post-SSA image that it's less black, and that is because of the presence of the somatostatin analog. And so because it decreases that background, you can see an increase in the uptake intensity in tumor sites. And so some tumor sites that were seen on the prior scan are now visible. You can see the green arrows pointing to a lesion up in the upper chest. You can see that that uptake intensity is increased. And then if you look at the lower part of the image, so you can see that black spot on the post-SSA image at the very bottom, that's the urinary bladder, and you can see several spots in the pelvis just above it. You can see more of them than you could see on the baseline scan. And this is a frequent phenomenon that we see on patients who are getting their first Dotatate scan on somatostatin analog. So it's just something to be aware of, that when we see this, we don't necessarily call that progression, because those sites might have been present before, but it was just that because we didn't have the benefit of the somatostatin analogs decreasing the background, we could now see those tumors better. But I'm going to now start summarizing how we think about cross-sectional imaging at Fred Hutch. So CT, as I said, is the mainstay for imaging the gastroenteropancreatic neuroendocrine tumors. We use MRI if there are liver metastases. Those are usually the modalities we use to determine whether there's progression or whether there's treatment response. And then Dotatate PET we use primarily for initial staging. We use it at the time of progression to characterize the full disease extent and to confirm how much progression or if progression has occurred. Again, looking at PRRT or lutetium dotatate treatment eligibility. And then we may use it to characterize sites if we're having a difficult time determining whether something is a neuroendocrine tumor, or if we are trying to figure out where to biopsy, we might use the Dotatate PET then. And then we do prefer PET-MR if liver metastases are present, but that's not a hard and fast recommendation. If you have PET-CT with an MRI or with a good multiphase contrast CT, that can also be sufficient. And then finally, just reorganizing when to use each modality. CT and MRI and Dotatate PET are often used at initial staging. Surveillance, again, CT and MRI primarily, and then Dotatate PET at time of progression. So thanks so much again for the opportunity to talk about how we use imaging. I'd like to acknowledge our multidisciplinary team. Dr. Jen and I and Dr. Iravani led our neuroendocrine tumor program. And then we have a robust nuclear medicine technologist and coordinator team, as well as our nuclear medicine. And on our oncologists, our interventional radiologists, led by Dr. Grace Laidlaw, and our surgical oncology and endocrinology teams. So thank you.